Welcome to the Gut Reaction, episode 2. Today I have a guest, Jennifer Kosova. She's the founder of Noble Family Medical and a highly skilled physician assistant with over 25 years of experience in medicine, with a background in emergency medicine and orthopedic oncology surgery. She's also pursuing fellowships in anti-aging, metabolic, and functional medicine. Jenn takes a consultative, patient-centered approach and meticulously investigates complex health issues. As an educator and medical detective, she is dedicated to advancing healthcare through personalized, cutting-edge treatment and empowering her patients to achieve optimal health. So on this call, Jenn is amazing. She's so insightful and intelligent about all things metabolic health and anti-aging. She did a bunch of blood tests for me, and on this call, not only she's going to go through my blood tests and all the tests that you would normally get from your doctor during your annual checkup and more, but also providing you guys a better understanding of what these tests are, what they say, and what your ranges should actually be. Because basically, we just want to be able to provide you guys the knowledge to understand what your blood tests and the tests you guys get from your doctors are saying, and additional tests that you should be looking to get and what they mean. Because knowledge is power, and once you guys have the power to take your own health into your own hands, you'll be able to make huge changes and improve your quality of life. So keep listening for the full interview and podcast with Jenn.
Hey Noah, how are you doing?
Good. How are you, Jenn?
I'm great. I'm great. So happy we got your results back and excited to go through them with you. Um,
Likewise.
so you had the full optimization consultation, which is a head to toe assessment looking at everything from your brain hormones, your thyroid gland, sex hormones, micronutrients, cardiovascular health, metabolic health, just basically a full head to toe scope so that we can get an idea of what biomarkers might be needing to be addressed before you develop illness. Because I find that most of my patients that come to me during their years when they're well, they go into their doctor and they get their labs and they're told everything's normal. But then, one day when they're 50 or 60, they are all of a sudden a diabetic or have a heart condition. And so the idea is to look at these things a little bit earlier before they cross over into disease and recognize when they're hovering on the border of being some issue. So in this first slide, I'm showing you here what we look for in the optimization consultation. And so I took a look at your cardiovascular health, metabolic health. We did a tiny little cancer screening. There are so many tests that you can do for cancer because cancer can happen in so many different parts of the body. Body composition, we use DEXA scanning to do that. Sex hormones, testosterone, estrogen, thyroid function, got a really close look at your thyroid. Brain health, we use a lot of these tests to determine your risk for neurodegeneration and also just things that we can do to help keep your brain cells healthier and provide them more fuel. And then your micronutrients, which are, your vitamins, your minerals, things that your body needs to perform all the chemical reactions it does with all these other things. So this first slide talks about cardiovascular health and what we really look for when we're assessing patients for cardiovascular wellness. And so the first thing obviously is blood pressure. Your blood vessels are simply tubes, right? They're tubes made of basically the same type of tissue as your skin. And so the higher your blood pressure, the more likely you are to rip those blood vessels. And when you cause little micro tears or big tears in those blood vessels, that's where strokes and blood clots can come from. And so ideally, you want your blood pressure to be around 120 over 80. I think when we measured your blood pressure, it was right around this. So we don't have to worry too much about you having high blood pressure, but we definitely want to keep an eye on this at least once a year.
I generally know that I have like chronically low blood pressure. I think at the doctor I just had it was like a 100 over 60.
Yep. And so low blood pressure is good as well. One caveat to that is you want to make sure you're getting adequate water because water takes up most of the volume of your blood vessels and that will contribute to your blood pressure. And if you don't have enough fluid in there, it can be low and you can have things like passing out and getting dehydrated and things like that. So keeping a good balance there of fluid when you have low blood pressure is a good idea. The cholesterol markers, that's where I typically see problems lurking in young people that have been told that their labs are all normal. In this country, we use a 10-year look ahead to determine somebody's cardiovascular risk. And so, they'll look at somebody young like you, 29 years old, and say, Noah, you're not likely to have a heart attack by the time you're 39. And so, we're really going to accept a very high level of cholesterol on you, and we're not going to worry about it the same way we would as if you were 50 years old
Mm.
and we found the same numbers. So, on your cholesterol, when I look at your LDLs, I really want them to be as low as possible. It's kind of like money in the bank protecting your blood vessels from plaques that will contribute to heart attacks and strokes. And so, your LDLs were a little bit on the high side, actually, for as healthy as you are and as healthy as I know you eat because I follow you on Instagram. Your LDLs are a little bit on the high side. They're 106. When I see that, the first intervention I usually recommend is a low saturated fat diet, increasing fiber. Those are two things that the average person can, apply to their diet and actually see some improvement on these numbers. But when I see this number stubbornly elevated, it usually means that there's some familial component that you can thank your mom and your dad for this biomarker being high. And so sometimes people need to be treated with drugs, with pharmacological agents, despite perfect diets, just to keep their heart safe and keep those blood vessels safe because you're going to need them for so many more years. And so we don't want any plaque in them now. So we'll talk a little bit more about that. And medicinal therapy, there are lots of different choices. Statins aren't the only choice, and they're not always necessary. A lot of people are afraid of taking statins for various reasons when it comes to glucose control and muscle building. There are other ways to get this number under control when it's necessary.
Can I
Um,
ask a question?
Please.
So, as someone who has maybe like genetically high predisposed to higher levels of LDL, but also someone that has low blood pressure, does that kind of push back an issue, and all of a sudden it just happens when I'm really old? Because they do say heart attacks happen. It's called the widowmaker, even if you're super healthy. So I'm wondering if I do have chronically high LDL just from genetics, but I also have low blood pressure, so it kind of pushes off the problem far into the future.
100%. You're right. So the blood pressure being low is a positive thing for you that will decrease your risk. And the cholesterol being high is a negative thing for you that will increase your risk. So the blood pressure being so good will temper the risk a little bit. As you get older, if you're still able to maintain that low blood pressure, it will still take some of the heat off of that cholesterol. But if you think of your blood vessels as tubes that carry liquids through them, the more cholesterol that gets laid down as plaque, then it's going to decrease the diameter of those blood vessels. And when you decrease the diameter, just like if you decrease the diameter of a hose, like if you think of a hose on a fire truck versus your garden hose, there's much less room for the blood to go through to perfuse those organs.
Mm.
And so the cholesterol decreasing that width of the artery will decrease the amount of oxygen that's going to the organs, and it will make your organs more stressed earlier. And we see that in the kidney and the brain primarily. And then usually the heart is the next stop. We start to see heart attacks at that point.
Yeah.
It's kind of like you can cook bacon and pour the grease down your drain only so many times before one day you turn on the water and now your sink is backed up.
Yeah.
And your cardiovascular system is a lot like that. You can pour a lot of grease into it, a lot of saturated fat, but one day that's going to be clogged. And that's the widowmaker, is that left anterior descending artery on the heart that causes heart attacks. And since it supplies your left ventricle, which is the most important ventricle of your heart that actually perfuses the heart and the rest of the body, that's why this one being clogged up is so dangerous.
That makes sense. And then
Yeah.
I know maybe some people that will be listening to this probably don't know the difference between arteries and veins. Maybe you could get a little bit into that too.
Yeah, absolutely. Arteries carry blood to your organs, and they actually have muscles that line their inner lining. Veins carry blood away from your organs, and they don't have any muscle in them at all. Which is why we get varicose veins when those veins wear out. They start to swell, and there's nothing you can do about those.
Right on.
Yeah. So the next stop would be inflammatory markers. So when you start to lay down plaque inside of a blood vessel, then the next thing that happens is that area gets inflamed, and that inflammation is what leads to the clot formation. And so not only do we want to keep the amount of clogging of the arteries down, but we also want to decrease inflammation. And the two biomarkers that we look at in the optimization consultation for that are the CRP, which is an inflammatory biomarker. Yours was beautiful. Yours was zero point 0.2, and I like to see it less than 3. And so
Awesome.
you're well below that. And then homocysteine. Homocysteine is actually an interesting marker of inflammation because if it's very elevated, you will be inflamed. And a lot of times that can be either due to a hereditary dysfunction of the way your body monitors inflammation and metabolizes B vitamins. When you have gross inflammation from something like leaky gut or some sort of autoimmune condition like Hashimoto's thyroiditis. So this is an actually very interesting test, but when it's high, it tells me there's definitely something going on that needs to be fixed, or else this inflammation is going to start to affect your artery
Mm,
walls. Your homocysteine was beautiful. I
thank
aimed
you.
for the number 8. Yeah, you were 8.2. You got an A plus on that one. Resting heart rate and heart rate variability is an interesting one, and I'm sure one that you deal with a lot in the gym with your clients.
Yeah.
Yeah. So your resting heart rate can say a lot about how healthy you are, how healthy your cardiovascular system is. And your heart rate variability can tell you a lot about how hard you can train. Sometimes when you've just tapped your tank from, overtraining maybe that week or getting dehydrated, going and working out in the sun, your next workout might be super weak.
If you want, I can tell you what my HRV is and resting heart rate is too.
Yeah, for sure.
My resting heart rate. This is why I love the Aura ring.
Yeah, the aura is great. Have you heard of the Morpheus?
No, what is the Morpheus?
It's a heart rate monitor. You wear, a strap that you wear like the old fashioned ones, but it has software in it that does a really good job at getting your heart rate variability. You put it on every morning and lay in bed when you first wake up for 3 minutes. It will look at your heart rate variability at that day and then determine how hard you can train that day. If you're going
Oh,
to overtrain and tap the tank too much to where you're increasing your cortisol and you don't have a good heart rate variability that day, it's going to tell you that you should kind of set the bar a little low on your workout, because even if you suck it up and really try to be type A and overachieve, you're actually doing your body more harm than good. And then it
oh,
will tell
interesting.
you when your tank's full and you've got like you can go all out, and go ham on your workout that day because you have a really good variability.
So very similar to Whoop or one of
Mhm.
the many. My average resting heart rate is 46, and my average HRV is past year has been 56 ms
Mhm.
milliseconds.
Yep. Yeah, those are all great numbers. A resting heart rate of 46 is like Lance Armstrong level. Like that's
I,
super duper
I
good.
think I've always just had really low resting heart rate too. I can probably credit some of it to my cardiovascular health, but my mom also is not necessarily high cardiovascular health, but she has a pretty low heart rate as well.
Yeah, typically your heart rate max and minimum is set by your genes. A lot. I mean, it has a lot to do with the way you control your environment as well, because the environment controls the expression of those genes. But it is somewhat set in stone from your parents. The heart rate variability, a little bit. There is a little more variability on that, and it's kind of like a tie together between your cardiovascular and your metabolic system, which metabolic is the next section.
And the
Um,
HRV is just the amount of like the difference in amount of seconds between your heartbeats, right? Or the
Exactly,
okay.
exactly. And it changes with inspiration and expiration based on the pressure of the blood inside of your thoracic cavity. Um, it's a very, very super scientific physics equation that I would never be able to repeat to you, but the tools and devices that we use to monitor it, like the Aura Ring and the Morpheus, are really great at doing that calculation behind the scenes and just giving you the raw data that you need to know kind of where you're at that day.
And a high HRV means you're well recovered, and a low HRV means you need to rest.
Exactly. Yeah. High heart rate variability is better for you, and a lower one. There are some studies lately that are coming out that say that the heart rate variability being low could be a sign of an undiagnosed cardiac abnormality.
Mm,
And when you see a really low one, they recommend getting an electrophysiology study with a cardiologist. Um, that's actually, there are different types of cardiologists, but the type of cardiologist that does that would be one that would do a heart rate monitor on you. It's a little, it fits in your pocket. You wear it for 28 days. It records your heart rhythm and it gets a lot of diagnostics that look at arrhythmias and issues that could be going on with the actual conduction of electricity through the heart.
interesting.
Those are people that are in the 20s and the 30s, that have significantly low heart rate variabilities. They can typically find arrhythmias on them. CT imaging is something that we didn't do for you. You're young. Typically at 29 years old, you would not get a CT of your heart. CT is radiation, of course. It's a small amount of radiation, but it's radiation nonetheless. But for people that are older, that have signs of elevated cholesterol that have not been treated for some time, it's always a good idea to get a CT of those vessels to see how much plaque is already there. And the crazy thing is, we're starting to realize now the more people that are getting these coronary calcium scans or CT angiographies, we're finding plaques in people that have previously been diagnosed as being low risk. Like we talked about at the beginning, only looking 10 years ahead and not treating cholesterol because somebody is young, we're finding that that's a bad call a lot of times, because in almost half of these people, we're finding that they already have plaques. And I'm hoping that that will start to make the, traditional mainstream internal medicine doctors and even cardiologists start to think about addressing people's lipid disorders earlier because of this, and not
Mm,
just classifying them as low risk.
interesting.
Lots of data recently, just over the last couple of months, from
Do
the
you,
Lipid Society.
do you feel like some of the barriers to entry to getting these tests and why people aren't getting them is because how expensive these tests can be in health insurance and the healthcare system and etc.
And the crazy thing is, yes, but the difference, the word expensive, I mean, think about it. They're applying it to the whole nation, right? So to do a lipoprotein A on everybody in the country is expensive. But to go pay for your own, even if you have to do it outside of your insurance, isn't incredibly expensive. And so, there's so many people out there that have kind of a borderline LDL cholesterol, in the eyes of many of the internal medicine professionals or cardiologists in the country. Their LDLs are borderline, but then when they go above and beyond and, work with somebody like me who does these expanded panels, and we pay cash out of pocket for them when necessary, we found so many patients that have elevated lipoprotein A. And lipoprotein A has just been classified as a causative agent of heart attacks. And some of these people, those numbers are being ignored. I actually have a young woman who just started working with me who's 34 years old, and her LDLs were very similar to yours, but her lipoprotein A was almost 300, and it should be below 50. So she has something hereditary. And so the fact that I found that in her at 34 years old, I can treat her LDLs aggressively and get them down to decrease her cardiac risk. But the thing I love the most about the fact that we found this is every single one of her relatives now can go get this test, and they might not be being treated because they've been classified as low risk. But once they see that these numbers are high, that will change the management, and addressing this now will hopefully increase their longevity, and decrease their mortality risk. So I'm really glad that people are kind of thinking outside of the box, not just taking what their traditional insurance model is providing for them, but doing what they have access to keep themselves healthy and their families.
Well,
Mhm.
thank God you found that.
Thank God I found that on her. Nobody would have ever checked it on her. And again, now that lipoprotein A is being classified as literally a causative factor in heart attacks, I think that that will hopefully change the way people practice and increase the ordering of it. The problem is, a lot of doctors don't want to order it because if it's not covered by the insurance, then they are going to have to get on the phone with your insurance company to try to get them to pay for it, or the patient's going to get a bill from the lab that they didn't expect. And I feel like maybe it's not ordered because of the work that has to be done to unwind all of that is just too much, and they don't have time. There's a huge burden on the medical system to begin with to treat our sick people. But if we start addressing these, we're not going to have as many sick people. And, I don't know, it just kind of becomes a catch-22 where we're neglecting finding these things, but then we're having more sick people to deal with, which makes it harder to try to find these things before they become sick. It's kind of a vicious circle.
That makes sense.
Mm-hmm. The next stop is metabolic health. And this is where I look at your glucose management, your insulin, which helps tell us how you're storing and utilizing your glucose, your liver function, your gut health, and your kidney function, because that's how we get rid of all of the things that we put in our body, how we metabolize things, how we change up our vitamins so that they're usable to our body. We create enzymes using this system. And so when I do your blood work, you had to fast from the night before, right? Yeah. And so when I'm looking at what's going on in your blood work, I'm supposed to be looking at an empty tank. You haven't filled your body with any glucose or any calories. So how much glucose is still in circulation? And when it's high, I know that one of two things is going on. Either during the day when you're eating, before you started fasting, you're putting too much glucose into your body. And that could be in the form of excessive carbohydrates or processed foods, which have a lot of simple carbohydrates, things like that. And so when I look at your fasting glucose, I like to see it below 86. 86 is kind of where we set the benchmark. If it's over that, then we know your body's not metabolizing as well as it should. And you could be at risk of storing extra glucose in your liver, or worse, storing it as subcutaneous fat. And that contributes to your fat burden. Your fasting glucose was 78. You're overachiever. Beautiful. And then you pair that with your fasting insulin. So your fasting insulin was low as well. It was 2. Your fasting insulin should be low because that tells me that your body wasn't given any glucose, so it didn't need to be secreted. And so you are efficient at when you squirt out insulin from your pancreas and when you don't need it. And so as soon as your body sees glucose, it's going to squirt out that insulin, help your cells suck it up, and then the insulin goes away.
So
Diabetics don't have insulin. That's why they.
I have a question for you, or
Yeah.
I think it would be good for you to clarify about this because I think a lot of popular, since like the carnivore diet and the keto diet have become very popular over the past couple of years. I think both you and I know when they talk about how people want to reduce a glucose response or an insulin response when they eat food. I think both you and I know that it's very natural to have a glucose spike or an insulin spike when you eat anything. Why do people see it as bad, and why shouldn't we see it as bad? And then, like, what is the main purpose of insulin when it is released from the pancreas?
Yeah, good. Very, very good questions. It's funny when you talk about diets because, the keto diet is a diet that's sometimes used in medical conditions, especially in people that have Alzheimer's
Mhm.
or kids that are prone to seizures. That's really where keto actually started. And the funny thing is, if you look at the way a hospital implements a keto diet versus how you see it done in the community, they don't even look similar. There's very strict regulation on carbohydrate and the amount of carbohydrates that you can use in a medical keto diet. And the reason why they do this diet is effective in some people is people that can't suck up glucose into the brain because the brain has become resistant to the insulin. Their only other choice is to go into ketosis and utilize the ketones instead of glucose. For your average person who doesn't have that issue, who doesn't have insulin resistance in the brain, then the purpose of the insulin when it gets excreted from the pancreas is insulin is a key that unlocks the door to the cells to allow glucose to be sucked in and utilized and then burned and create energy. And so if that key isn't in that lock, opening up the cell for the glucose to get in, the glucose circulates and has nowhere to go. And it clogs up the liver and it clogs up your subcutaneous fat. And that's what happens in a diabetic. Let's say they eat a donut. That glucose is circulating in their body till their glucose goes from your 78 to 100 to 110 to 120. It can't get into the cells. And so it just spills over. And they have to stick themselves with insulin in order for those doors to be unlocked and the glucose to come in. And then everything goes back to normal again. In the absence of that, that's when you start to get diabetes and your cells can't have the benefit of that glucose. And it affects your cellular energy, worsens your mitochondrial function, and starts to kill off those cells. And that's a vicious circle.
I think there's so much fear around, in today, because of social media, around people have glucose spikes, and then people are afraid of what insulin is. Um, we both know insulin is like a very normal, an important hormone in the body that helps our bodies convert glucose into energy. Why?
Exactly.
Exactly. Yeah. I guess my question is, can you tell us it's silly to be afraid of insulin or glucose spikes in the body?
Yeah. So when your body starts to release insulin because it needs to unlock those doors to get into the cells, and those cells become resistant to that key, your body will start then to make more and more and more insulin, saying, "Hey, let me in. I've got all this glucose out here. Let's open up this door. You're not listening to me." And then the pancreas just keeps squirting out insulin to try to get that effect, but the effect is blunted. That's the danger of a prolonged increased insulin, is it tells us that your body is resistant now to that message. And so if I were to look at your blood levels and see an insulin in the 20s or in the 30s, that would tell me that Noah is insulin resistant, because look at all the insulin it's taking in order to get the body to accept that glucose into the
Mhm.
cells. And so when you hear about, you don't want to have an elevated insulin level, you don't want it to have to be super elevated in order to work. You should be efficient and be able to secrete a tiny amount of insulin in order to open those doors. Um, Insulin resistance, that typically that mechanism that causes that is usually caused and starts at the level of the muscle, which is why if you can get people to move their muscles specifically after eating a meal, there's actually a cheat mechanism that your muscle has. It doesn't even need insulin. Your muscle cells actually have this cool mechanism that when they sense glucose and they need glucose, it sends these little straws to the edges of the cells that can suction up the glucose without any insulin. It's independent of insulin. And so just the activity of moving the muscles can help diabetics need less insulin in order to suck up their glucose. And so it's really not the insulin spike that's a problem. It's when it has to spike so high in order to get the effect.
Got it.
hmm And then the reason why you don't want persistently elevated insulin is because insulin is a growth factor, and growth factors, anything that makes your cells grow, potentially can stimulate cancer growth.
Mhm.
Right? Because cancer tumor cells want to grow too. And so growth factors for some tumor cells can be what they need in order to get bigger and worse and metastasize. And so being in a chronic state of high insulin, it can be bad for you because of that mechanism. Liver function, your liver is responsible. It's like a treatment plant. It basically takes all the blood that's flowing through it and will make tiny changes to the chemicals in order to either pee them out or poop them out. And if your gut isn't working great, then it's not going to poop them out. And so in patients that maybe their liver is working great at converting these enzymes over, but the gut's not working great and it can't get them out, that's when you start to get these toxic metabolites recirculating. And this becomes really important in people that are on hormone replacement therapy. Because when I check blood, I can only check for the active levels of hormones. The metabolites that are created by the liver and maybe kept in by a bad gut really need to be checked in the urine. And so when we start to see problems with liver function or gut health, especially in hormone patients, I like to do a urine test on them to check the metabolites. Your liver function was very good. You did have an interesting elevation of one of the tests called a total bilirubin, um, which sometimes I can see in patients. This can be hereditary, actually, just the way your body breaks down red blood cells. There are a couple of other chronic conditions like porphyria that can cause elevated bilirubin. Typically in these patients, though the levels are very high, you'll also see some other signs with the iron and some of the micronutrients. Usually when I see this level, I ask for old liver tests to see if it's always been this way, kind of like a fingerprint. It can be a sign of some duct problems within the liver ducts, typically in women that are on hormone replacement or have had multiple pregnancies. You can see some gallstones, and that can make this number go up. But 9 times out of 10 in somebody young and healthy like this, like you, this is just an incidental finding that will always look this way and has nothing to do with how effective your liver is. It's more of a ductal number. Kidney function. Your kidney function was great, but I am sure that you have heard a lot of people saying that you shouldn't take creatine because it's going to elevate your kidney function, your creatinine.
Yeah.
Have you ever heard that?
I have.
So creatinine measured in your blood is actually not a measurement. It's not a direct measurement by the lab. It's actually a calculation that they use. And anytime you're applying a calculation to a blood test, it can be very variable depending on the size of the human, right? Because if you look at me versus the rock, our calculation might be a little bit different. And so we're going to be at different ends of the spectrum, even if we actually have the same blood creatinine levels. So in your more muscled patients, you're going to see that this number is more on the higher end. You'll also see that this number will go up with dehydration. But there have been study after study that shows that creatine, the supplement, does an excellent job at fueling your mitochondria, which is where you make your cellular energy for every single cell in your body, whether it's a hair cell or a muscle cell. And it has nothing to do with your kidney function. There are a couple of other tests that I do. If I get a very large muscled person that has an abnormal creatinine, I'll do a test called cystatin to get a closer look at that. That isn't a calculation, and it's actually more diagnostic. And 10 times out of 10, that number is normal. This is an interesting metabolism test that we do, the hemoglobin A1C. Have you ever heard of that one?
Yes, it's the diagnostic test to see if you have diabetes or not.
Exactly.
Blood sugar level.
Blood sugar. So, we already talked about your fasting glucose, but this hemoglobin A1C test is actually a 3-month report card of your glucose. And so it's because they test the inside of a red blood cell, and the blood cell lives for 3 months. And so it's 3 months of data. And I found this slide. This is such an interesting demonstration of how, as your hemoglobin A1C goes up, so does not only your risk of diabetes, which is in this area here, but your risk of death too. They looked in this study at per 1,000 people, how many deaths they saw in patients with these particular hemoglobin A1C numbers. And so when we start, let's say I start working with a patient when they're here and, their doctors told them, oh, this is great, your numbers are beautiful. Well, it is. It's not 6, but I would rather see them here and then here and then here because I know I'm going to decrease their long-term mortality. We also now know that Alzheimer's disease is a neurodegenerative disorder that has a lot to do with the insulin sensitivity at the level of the brain. And we know that as we worsen our insulin sensitivity in our body, starting with our muscles, that it will also affect the brain. And so getting diabetes actually is a setup for getting Alzheimer's disease. Just another reason to keep an eye on this.
Fascinating.
Yep. We used to think it was more just related to poor antioxidant function, chronic inflammation, bad blood flow, and all of those things do contribute to the plaques that are formed from Alzheimer's disease. But this metabolic insensitivity really is looking like it's actually the key to preventing progression of neurodegenerative disorders and Alzheimer's. And the time to do it is when you're between 30 and 60, because once you start to get that scarring, those plaques in the brain that form, there aren't very good drugs right now that we have that fix it. And so the key is really preventing that from happening. And the time to do that is before we even think about the word Alzheimer's. The sex hormones are my favorite part. We look, we always think of testosterone, well, at least I think many people do think of testosterone as a male hormone and estrogen as a female hormone. Um, and it is true to the extent that testosterone will express more male characteristics like muscle growth, hair growth, oily skin. And estrogen imparts more female characteristics like an hourglass shape and breast growth and things like that. But I don't think a lot of people know women, we actually have more testosterone than we have estrogen in our bodies.
Hmm. I actually had no idea. I didn't know that.
Most people don't know that. And a lot of people don't know that men actually need estrogen. It's cardioprotective, it's good for your heart, good for your bones. And testosterone actually, as it gets metabolized in your body, will become estrogen at one point. And so your testosterone will convert to estrogen as your body is metabolizing it. And so both of those things are really important to have balanced in both men and women. The brain is the master control center when it comes to both testosterone and estrogen. There are pre-hormones in your brain that tell the testes and tell the ovaries to make these things. And those are the FSH and LH. Prolactin is another hormone that comes from the brain that regulates milk production when a woman's pregnant. And I check that one in all people, even when they're not pregnant, because believe it or not, tumors of the gland that produces the prolactin are present in about 10% of the population.
Hmm.
They're not cancerous, but they can hypersecrete prolactin, and they can also put pressure on the neighbors, the neighbor hormones, and cause dysfunction with FSH and LH, which will then spill down the road and create problems with estrogen and testosterone. And sometimes the problem all lies with a tiny little tumor right here.
Hmm.
So that's always good to screen for. And then not only do we look at testosterone and estrogen, but then we also look at the breakdown products. Like I said before, your testosterone will become estrogen. So I look at that in men as well. And then DHT is testosterone's metabolite that actually is able to pass into your brain. And that's what's good for your libido. And your aggression is a bad word. I think the competitiveness or the types of things that you see that tend to be more male characteristics from a brain standpoint. And those are all caused by DHT, which is the metabolite of testosterone that happens to be a lot stronger than testosterone in its androgenic input.
And what is the difference between testosterone and free testosterone? Like total testosterone and free testosterone?
Excellent question. It's useless to check just your total testosterone. It tells me nothing about what your body's doing with it and how much you have to use. Because the majority of testosterone, 98% of it, ends up getting sucked up by a little sponge that circulates in your blood called the sex hormone binding globulin. So that's a protein that will literally suck up your hormones. It will suck up your testosterone, it will suck up your estrogen, and it will even suck up your thyroid. And so when your hormones are stuck to this sponge, you're not using them. And so that takes about 98% of that total testosterone out of circulation. And so you really have to know the free number, how much of it isn't attached to that sex hormone binding globulin. And that's the number that you have to work with. And in a man or a woman that's utilizing testosterone effectively, that doesn't have a lot of inflammation and isn't accumulating a lot of toxic metabolites, we want that ratio. You want to have about 2 to 3% of your total as free usable hormone. And that's really a better measure of how much you have to work with.
Understood.
Really good question. And the higher that number goes, we see that number elevated in women that have been on birth control pills because of the fake hormones, causes the body to hypersecrete that sponge trying to suck them up. And so those women tend to go into menopause with much worse problems because their body will need a whole lot more estrogen to be able to have free estrogen that's not attached to those sponges. Same thing with thyroid. Some patients suffer so greatly from thyroid symptoms. They know they have a sluggish thyroid. They know that they're gaining weight and that their metabolism is off, but their doctor says, no, you've got plenty of thyroid hormone. Well, you might have plenty of thyroid hormone, but what if most of it is attached to a really high sex binding globulin and you're not able to use it? You might have normal numbers on your blood work, but that doesn't mean that your body has enough of it to use to bind to the receptors to do its job.
Hmm.
Really important to know all of those numbers. Hormones
None
are
of that is done in like a normal conventional blood test that doctors ask you to do on your, yeah.
No, and the crazy thing is, I have so many, especially women, that come to me and say, "I've asked my doctor to check my hormones, and they won't. They say that it's not necessary." Or I asked my doctor to check my hormones, and they sent me to the lab, but it's important what day you're ordering them, right? If I'm
Yeah.
looking at a woman going into menopause, I need to know her levels at the beginning of her cycle. If I'm looking at a woman who's having really bad menstrual issues or infertility, I need to look at those numbers towards the end of the cycle. They tell me two totally different things. And so hormone screening is just almost non-existent. And then you combine that with the fact that out of all of the OBGYN residencies in the United States of America, only 30% of them have any training in postmenopausal hormone therapy. It's an
Huh.
astonishingly
That's
low number.
disappointing to hear.
That's who we're expecting to do the
Yeah.
job for us, right? We're expecting that those professionals are adequately educated to really understand how to regulate, assess, and control our hormones. And that's just very far from the case,
That's
unfortunately.
disappointing.
Yeah. 70% of those, by the way, have only had 2 hours worth of lecture in the topic. That's a study put out by the Mayo Clinic in 2023. Um, Next slide is thyroid function. We touched on it a little bit, but kind of like the sex hormones, the thyroid is also regulated by the brain. You have a thyroid releasing hormone and a thyroid stimulating hormone that both come from the brain and then goes to the thyroid gland, which is in the front of the neck, right in front of your Adam's apple if you're a male, or in the front of your neck if you're a female. And this hormone, shaped like a butterfly, it first creates a hormone called T4, and that's the pre-hormone. And then it loses an iodine. It has 4 iodines attached to it if you're into chemistry. It loses one iodine and then it becomes T3, which is the active hormone. And just like with the sex hormones, we want to know the free. I mean, we can know the total, that's great, but really the free is what's important. How much
Hmm.
free hormone do we have? When we see a low free hormone, we know that that's going to affect metabolism. It can cause it to be very difficult to lose weight, even if you're following all the rules and doing everything. Eat less, exercise more isn't always the answer. Sometimes it really does lie in the thyroid gland or in the hormones themselves. And then very commonly underscreened for are the thyroid antibodies. Thyroid antibodies are when your own body is attacking the thyroid gland. It's sensing that it's a foreign invader for some reason. A lot of times, this is how we diagnose a celiac disease, believe it or not.
Hmm.
People that have gluten sensitivity, a lot of times will develop thyroid antibodies because the thyroid and the gluten protein look similar to the body. And it's a kind of a false overreaction of the body, if you will. And eliminating gluten from the diet sometimes is enough to decrease this. But nobody tests for this. You're not getting this on your traditional panel. Traditionally, your doctor is ordering a TSH, just a thyroid stimulating hormone. That's it. Not checking anything here.
Hmm.
Missing a lot of opportunity
Yeah.
to and a lot of opportunity to address people that maybe they have a high sex binding globulin. It's sopping up all this and it's just not available to be used. Heart rate variability we talked about before. Somebody with a very abnormal heart rate variability, this very well could be coming from a thyroid dysregulation as well. Micronutrients. There are huge micronutrient tests that will test for 30 different micronutrients inside of the cell because we don't really care what they look like in the plasma. We want to see what they look like in the cell. Plasma is only going to tell you basically what you've eaten in the last 24 hours. Whereas when you look in the cell, it's kind of like the hemoglobin A1C test that it gives you 3 months worth of data. But your vitamin D, very important, not just for bone health. I think that's how most people know it, but COVID has really shined a light on how important vitamin D is for your immune regulation. Or your immune function. Being out in the sun will help increase your vitamin D, but for many people, it's not enough. Especially if you're dark skinned, you're going to have a harder time making vitamin D simply from the sun. Many times, in order to get to the levels that I really like to see, like around 60, we need to supplement. Let me see, what was yours? Yours was 60, and you're right on the numbers on all these. It's like you studied for this test.
So I have a question about vitamin D. Two questions, actually. So number one is that I heard a rumor that to get, exposure from the sun, or to synthesize, or what am I trying to say? To get vitamin D from sun exposure, it has to be just on your torso. Is that true or false? No?
I
Okay, I
believe
figured it was false.
it's false.
Okay,
Your
that's what
skin
I
cells
figured.
have the ability to do that conversion.
Second, melanoma is a real concern for a lot of people. Is it possible to get enough sun exposure, get enough vitamin D, and not experience, getting skin cancer?
Very good question. And I think that is kind of individual dependent. If you're prone to melanomas, how much exposure is it going to take for you to develop one? I'm not sure that there's a good metric for that, but you're correct. If you're blocking your skin to protect from melanoma, you are not going to get the benefit of the vitamin D. And so supplementing really is the best way. There aren't that many people whose labs I check that aren't supplementing that have adequate levels. In my opinion, it is better to protect yourself against melanoma. It's better to protect yourself against melanoma than to increase your risk of melanoma by trying to get your vitamin D that way, especially since it's so easy to supplement.
Yeah. I take a 5,000 IOU pill every day.
Absolutely. 5,000 is a great one. Also, you can take, for some of my patients that don't like to take vitamins, I have them take 10,000 milligrams Monday through Friday and then take the weekends off. And then there's also a prescription 50,000 unit vitamin D that's a once a month.
50,000. Wow. If you're taking that much vitamin D in one sitting, do you feel a difference when you take it?
Bad question for me. The only thing I feel a difference with is exercise. I have plenty of patients that get vitamin B12 drips and they have so much energy. For me personally, I must have a very stubborn constitution. I don't know. I've never heard anybody tell me that their megadose makes them feel any way or another. It would be good to look at the data. Honestly, I feel like the body needs a steady drip of these things. I'm not a big proponent of the monthly dosing for that reason. It's not my go-to, but for patients, I have one patient in particular, I literally have to force the vitamin in her mouth in order for her to take it. So I put her on the once a month one because I know, she won't be compliant. And, part of the approach of personalized medicine is if I tell you to do something you're not going to do, well, I haven't solved your problem. I have to help you figure out a way that you're actually going to do it. And, so sometimes you do things in a little bit of a different way to accommodate getting it done at all. Not letting perfect be the enemy of complete.
Totally.
Vitamin B12, great for energy. You need it for your blood cells. But more importantly, it is a cofactor in almost every single hormonal reaction you have. If you're not getting vitamin B12, your hormones definitely, even if you have great free levels, you might not be using them efficiently because you're missing a cofactor. It would be like opening up a car factory and trying to build as many cars as you can, but then you ran out of steering wheels. It's going to limit your ability to make a car simply because you're missing that tiny little steering wheel. Iron is great for carrying blood around your body. That's its job. It's the vehicle that your body uses to carry blood and drop it off at organs. The less iron you have, the less ability you have to do that, and you can't build as many red blood cells. You also don't want to have too high of an iron level. Iron can be inflammatory if you have too much of it. Some people have some people have deficiencies in the ability to get rid of iron, and their iron will accumulate and scar their liver. It will actually lay down, and if you look at these people, you can actually see iron deposits in their liver, and that can be a genetic thing. And that's something actually diagnosed that on a woman in her 30s, where her iron stores were through the roof. And then we did a genetic test on her, and it turned out that she had a genetic variant, a very common genetic variant that 30% of people have. Hers was just overly expressed, causing her to really accumulate iron. And for those people, they need chelation therapy, which is a big process of multiple IVs in order to try to get that iron out. Can be
Interesting.
quite dangerous. Mm-hmm. Body composition. This is also kind of an area that I totally nerd out. There's lots of ways to measure your body composition, basically how much fat, how much muscle mass, and how much bone mass you have. My favorite is the DEXA scan, because it also really gives a great idea of not just bone weight, but bone density, which is important, especially as we age, especially for us menopausal women, because we start to lose bone density, and losing bone density sets us up for broken bones. Broken bones when you're an older person significantly increases your risk of mortality. If you break a hip once you're 60 years old, your 5-year risk of death goes up by 50%.
Holy shit. Sorry, excuse my French, but I didn't know that statistic was so high. Wow, 50%.
50%. And if you break it after you're 80, 80%, sorry, 80%.
Is that because, I mean, my imagination would be if you break a hip, you become more sedentary. But is there other things going on beyond that that, lead to the higher percentage of death?
It's the sedentary. It
Mm.
absolutely is. It's the bed rest. Even just a week of bed rest, they've biopsied muscle fibers in people that have been at bed rest. And you can see, I can't remember the actual statistic of the decrease, but a tremendous decrease in muscle density just from 1 week of immobility. And so,
Interesting.
yes, these people get decompensated and decompensate very quickly. They develop pneumonias from not moving around and exercising their lungs and their cardiovascular system. They develop blood clots in their lower extremities because their blood is not being pumped back up. We said those veins don't have muscles in them. So your veins depend on the pumping of the muscles around them to send the blood back up. And yeah, these people just decompensate very, very quickly. And the numbers are astounding. And it's something that we don't think of a lot when we're younger because we don't think about falling. A kid falls down and they get right back up. And the older you get, the harder it is. But yeah, this is why you want to make sure your bone health is protected. And having adequate hormones and not losing our estrogen during menopause is the number one way of preventing bone loss. There are no drugs that are more effective than estrogen in both men and women at preserving bone density as we age. Preserving muscle mass is super important, and a DEXA scan is a great way of making sure that you're preserving your muscle mass, especially now that these weight loss drugs like Ozempic, Mounjaro, the GLP class of drugs are becoming more and more used. A lot of the negative that you're hearing about these is directly contributed to the fact that people stop eating protein and they don't work out as much because the drug is doing the job for them at taking the weight off. When they look at the scale, the numbers keep going down. But the bad thing is the only two ways in science at this time at all in the world to build muscle is to eat protein and to resistance train. There is no other way. There are no drugs that do it. You have to either eat protein, resistance train, or ideally both. And so if you stop eating protein and you're decreasing your appetite by using an exogenous drug and you are not exercising, you are going to melt the muscle right off of you, which accounts for so much of the weight that they see going down in the scale.
Yeah.
And that's dangerous. These class of drugs are very good. I like to use them in select patients, and I use them with a very, very strictly guided program to make sure that none of those things happen. Patients have to make sure they're getting in adequate protein, about 1 gram per pound of ideal body weight, not their current body weight, but their ideal body weight. And then resistance training, ideally at least 2 days a week, hitting, all the muscle groups. And so if they'll only get into the gym twice a week to do it, then I'll have them do full body workouts on each one of those workouts so that they're hitting all the muscle groups 2 times during that week. And then as they progress the amount of time that they use with weight training, then they can do, upper body, lower
Mm.
body, some sort of split in their workout. But we really take great measures not only to protect the muscle from going away, but to monitor it through DEXA scans and serial DEXA scans. Um, Fat is the other metric that we look at. And specifically, I love this metric that we get from the body scans because visceral adipose tissue has the most correlation with your risk of diabetes, heart disease, and overall risk of death. You can see, I like to show off this patient because she started with a fat mass of 2.66 pounds of fat around her visceral area, around her organs. This is just pure organ fat. This is the beer belly on your uncle, right? That, you
Yeah,
see these older guys in my family, we have a few of them that look like they're pregnant. This is the fat there. 2.66 pounds down to under 1 pound.
that's
This
amazing.
is significant. This probably bought her another decade of life, honestly, or a decade of life without disease at the very least. This is a great metric to keep an eye on. Your hydration going in for these scans is really the biggest factor that can throw off the consistency and the accuracy of these numbers. So the more or less hydrated you are, you can definitely get variability here.
And I know we were just talking about bone density. So I've never really broken a bone in my life. Would that be because my Z-score is a 3 and I just have
Yeah,
incredibly thick, dense bones?
yeah, you have dense bones. So bone is built in response to stress. That's actually Wolff's law. It's a
Yeah.
physics law, and so that's exactly why you do farmer carries, right? And why you wear a weight vest and rucking and things like that. That's why all those things are important. And I use that a lot with my patients, especially menopausal women, having them walk with some weights or just do simple farmer carries. Because if you think about it, you're putting stress on the lumbar spine and increasing the bone density there. And where your hips meet your pelvis, those are the two most common areas to break if you fall
Mm.
or to, wear out in general. And so putting a lot of stress and trying to increase the density of those particular bones can really be accomplished by those types of exercise and that kind of training.
So for those of you listening to this, I'm 30 now. I started lifting weights when I was 14. So that's 16 years of resistance training. So if you want high bone density, just lift weights consistently for a very long time.
Totally. I
Yeah.
mean, if you're taking calcium and you're taking magnesium, then you're giving the body the ingredients. But if you're not applying the force, they're relatively useless. You
Yeah.
might be able to make up for some of the law, because your body's constantly remodeling bone. An interesting fact, your tibia, your big shin bone that goes from your knee to your ankle, you remodel that from the inside out with the bone being broken down and new bone being laid down. You get a new tibia every 8 months.
Oh, wow. I did not
Isn't
know
that
that.
crazy?
That is
Your body
wild.
It's wild. You have osteoclasts that eat bone from the inside and osteoblasts that build bone on the outside. And they're constantly recirculating that pool of bone. And it's about 8 months total for that whole transition. The body
Fascinating.
is amazing, fascinating. So it really does tell you it matters. And it doesn't matter if you've been unhealthy your entire life. If you start now and you really work on your bone, within a year, you're going to have more solid bones, much better than you had before. And it doesn't have to be that you've been acting this way your whole life. This could be a new changed behavior that really improves your body composition in a very short period of time in a very meaningful way.
Mm.
Mhm. Brain health. We talked a lot about brain health when we talked about blood sugar control, genetics, or blood flow and blood pressure, inflammation, cholesterol. Basically, whatever is good for your heart is good for your brain. And so, the great part about keeping yourself healthy is that a lot of these things kind of overlap each other, right? If you're paying attention to all of these things, you are going to end up automatically affecting good brain health. One thing we didn't talk about with genetics was this ApoE gene.
I know I'm excited to hear my test results.
Yeah, I'm excited to give them to you. So yeah, the ApoE gene is a gene that you have in your body, kind of like your coding for your blood type. Your mom gives you a copy, your dad gives you a copy, and then you're either an A positive or AB or an O. But with the ApoE gene, this is a gene that determines how your body is utilizing cholesterol and cleaning up damaged cells, and how effective you are at doing that. And so, oh, sorry, my slides are a little out of order here. And so this is Noah's ApoE genotype. You'll see Noah's mom over here and Noah's dad over here. And here's Noah. So your genotype was a 3-3. And that's the most common
Okay.
combination. Yep. So we don't, well, we know now from looking back at people that have Alzheimer's, that have significant neurodegenerative disease, and looking back through history at what their gene type is for this particular gene. And from those studies, they found that people that have an ApoE4 genotype, either one or two copies, have an increased incidence of Alzheimer's. And because what's good for the heart is good for the brain and vice versa, and it has to do with cholesterol management and cellular cleanup, then those people are also at risk of cardiovascular disease. If you have one copy, you're about four times more likely than Noah to have Alzheimer's. And if you have two copies, you're about 12 times more likely than Noah to have Alzheimer's or
Wow.
cardiovascular disease. So we know, because you are a 3-3, each of your parents must have at least a 3. We don't know what their other one would be though, right? Because they gave you one of theirs.
Yeah.
And so your mom could be a 3-2, your dad could be a 3-4. We don't know that, but we do know yours now.
Awesome. Glad to hear it.
So
I
the
know my
response.
partner is very interested in this test because Alzheimer runs on one side of her family.
Yep. Yeah. I was talking to a patient earlier today about this, and she's terrified to do this test. She feels that if she knows the results, that it's going to make her nervous. And I can't disagree with her.
Yeah.
When I did the test, I was very anxious. I just knew I was going to be a 4. I have no idea. I wasn't, but for some reason I had in my head that, this is it. And if I'm a 4, what does that mean to me? And, ultimately at the end of the day, what it means is you just have to take this all a lot more seriously, right?
Yeah.
If you know your body is not good at cleaning up, and you know your body is not good at dealing with cholesterol, well, then don't give it a lot of junk to clean up, and manage your cholesterol and start young. But again, this is one piece of the puzzle that I think traditional medicine, since we're not testing for this traditionally, we're failing to provide people with this information when they're young enough to do something about it. And that's, I think, the key is having
Yeah.
this data when you're young enough to still affect change. Because when a 70-year-old goes into a neurologist and gets diagnosed with Alzheimer's, those plaques and tangles are already there. The things that they would do to help prevent those plaques and tangles, it's too late. If they don't drink alcohol, and make sure they have good antioxidants, and make sure that their hormones are detoxing appropriately, not putting excessive burden on their liver, it's too late for that. That the damage was already done. And so for people who can address this early, they're going to see more protective effects.
Mhm.
This is the slide I skipped earlier. Again, we do very basic cancer screening in this particular workup, because we're looking at so many different things, and we're looking for danger lurking underneath these previously normal labs. But one test I always do on men is a PSA. The PSA stands for prostate specific antigen. This is a hormone, an antigen, a protein that gets expressed from your prostate. And when the prostate is growing, it will express more and more of this protein. And so a growing prostate doesn't always mean cancer. Sometimes a man's prostate is just stimulated so much by testosterone that it just grows and grows and grows. And it can put pressure on the urethra, making it hard to get urine out. That can elevate a PSA, but also a prostate cancer growing within the prostate can cause that elevation. And
Mm.
so not only do I check for an elevated level, anything above 4 would require an evaluation by a urologist, but I also check to make sure that this number doesn't double between evaluations. So let's say you start at 1, and that's a very low number. It's a normal number that doesn't require any investigation. But let's say I check your blood in 6 months or a year, and now it went from a 1 to 2. Well, it shouldn't have doubled over the course of a year or 6 months. And so sometimes that could be a reason for concern and a way to catch a really early prostate cancer before it becomes a really serious one. So not only do we check for the upper limit of the number, but also for any doubling of that number in a short period of time.
Mm.
Similarly, with females, ovarian cancer is probably one of the hardest things to screen for in women. The ovaries tend to be really hard to see, even with ultrasounds, just because there's so much real estate down there. You've got your bladder and your colon and your uterus and your ovaries, and they're all kind of crammed into an area, and they can be flipped over and behind other things. And so sometimes an ovarian tumor isn't detected until it's already very aggressive or has spread. And ovarian cancer is no joke. This CA-125 is a very cursory, very non-specific screen, but when it's elevated, it means that we have to do deeper diagnostics than we would normally do, that we would do an ultrasound or maybe even an MRI to get a closer look on a woman that had an elevation here. So this is one I use to screen for with women, just to make sure that I don't see any acute elevation there. And that was the end of the breakdown, but
I
I
love that.
imagine that you have some questions.
I do. Well, do you think it would be helpful to go over my full tests just real quick after we did all that breakdown?
Absolutely. So let's close this down real quick. I'm going to go back to you. Okay. So now I can see you. So your whole test starting from A to Z.
And if you wanted to, you could share it on the screen. I honestly don't.
Oh, sure. Here.
I'm
Let
pretty
me.
transparent.
All right. So this is the actual slip that comes back from the lab. And you'll see here, first I start with a complete blood count. That will tell me if you have either elevated or too low of white blood cells. White blood cells are the fighters in the body. They fight infection. If you had pneumonia, I would expect this number to be elevated, or a urinary tract infection, this number will go up. Your number is quite normal. When it's low, I worry about your body's ability to make white blood cells. Sometimes you can find problems or cancers within the bone marrow, causing a suppression of this. Sometimes it's simply suppressed from a virus. Even though these are fighters, sometimes viruses actually can shut down this system. And so you'll actually see a lower white blood cell count.
Mm.
Hemoglobin and hematocrit, those are your red blood cells. That tells me if you have adequate red blood cells carrying oxygen. Sometimes these numbers are low because you don't have enough iron. And so, the iron test later on down the road will kind of give me a tip and tell me if that's why this might be low. Your number is great. I check these numbers also in my patients that are on testosterone, because testosterone actually increases your hormone erythropoietin, which creates your red blood cells. And so sometimes in my testosterone patients, they're making too many red blood cells, and I have to actually do a therapeutic phlebotomy to drain a little bit of blood off.
Interesting.
Platelets are your clotting factor. It's what makes your blood stick together so you don't bleed to death when you cut yourself shaving. You also don't want them too high, though, because that can form blood clots inside of your vessels, and those can be deadly. These percentages here. This is kind of cool. This is what your blood cells, your baby blood cells, are going to be when they grow up. And so neutrophils will become white blood cells. Lymphocytes also will become white blood cells. Eosinophils sometimes will be elevated if you have chronic allergies, things like that. Glucose, this was your fasting glucose we talked about. It was 78, very normal. I like to see it below 86. BUN and creatinine are your kidney function measurements. The BUN, when it's a little bit high, sometimes can be a sign that you are a little dehydrated. You can see that number go up. Your creatinine was towards the upper limit, but I suspect that's because you're a well-muscled person.
Mm-hmm.
and it's still very well within normal limits. It's not super elevated. Uric acid is an interesting test that tells me how well your body is dealing with fructose and breaking it down. Fructose, even though it sounds like a good thing, it's actually not great for you. It's found in fruit. And if you're taking the fruit with the fiber, the skins of the fruit, then it kind of offsets the negative part of the fructose. Because fructose, historically from evolution, really was to store fat, store glucose as fat, and to be used for later when we couldn't find, a banana on a tree or fruit to eat to sustain us while we're hunting for some meat to eat. And so I aim for a level of around 5.5. Men tend to run a little bit higher than women. Women, I aim for 4.5. Yours was a little on the high side, nothing that I would be super excited about. But if you were having a problem losing fat, I would maybe probe your diet to see if there's some hidden fructose in there that we're missing.
Hmm.
Uh, Sometimes in non-caloric snacks where they advertise that there's no that it's low in glucose, you'll find that they actually are using like high fructose corn syrup or something, and that can cause this. I see that in some of the keto stuff, unfortunately. The keto snacks, a lot of times just calorically, they end up being way above a calorie load. And it will offset the benefit of the actual keto part of it. And so you're providing, so much of this non-caloric chemical in there that's kind of going to get stored as fat instead of glucose. I don't know if you do any of like those keto bars or anything like that.
No.
I doubt it. Not with the way you cook. Um,
And the numbers right above were just my electrolyte levels.
oh yeah, sorry.
The
So
potassium chloride.
sodium, potassium chloride, electrolytes, exactly. Very narrow windows of these. You see, your potassium and your sodium are the main regulators of your electricity of your cells, especially your heart muscle, causing is what causes the heart to expand and contract. And so, really, any major fluctuations in these can kill you. Potassium and sodium are very delicate balance, regulated by your kidney. Um, Carbon dioxide. It tells a lot about the pH of your body. If you're acidotic or you're not typically alkalotic, but if you're acidotic, that could be a sign of metabolic resistance, difficulty metabolizing your nutrients. A lot of times you see that in diabetics where they're acidotic. Calcium, of course, for your bones. Total protein, albumin and globulin. Albumin and globulin are types of protein. Your total protein number is perfect. Albumin, globulin, perfect. Total bilirubin, that's the number we talked about before. I suspect that this could be just your fingerprint and the way it looks. Your other liver numbers are very normal.
Hmm.
I like that. Actually, your liver numbers are tiny bit on the high side, 22 and 30. I like to see these in the teens, but we're splitting hairs here.
Okay.
A glass of wine will do that as well. Your GGT tells me that you're not drinking a lot of alcohol. This is really one of the main numbers that will go up when I see patients that have a really super high fatty diet, high in saturated fats, or they're drinking a lot of alcohol. This is usually the first number to go up. This is just a ratio of these two numbers here. You see, a lot of these kidney numbers are calculations. Same thing here. The reason why this ratio is high was because the BUN was a little bit on the high side. And so it's pulling up this ratio because it's on the numerator, not the denominator.
That makes sense.
Mm-hmm. Your hemoglobin A1C was 5.5. So if we go back to that chart, actually, I would really get you a little bit more regulated here because you're here right now at 5.5. Now, granted, you're at the lower end of this range, but I would love to move you down to this range. One of the best ways of doing this is to increase the fiber in the diet. And one of the other best ways of doing this is to apply some method of intermittent fasting. And intermittent fasting is a word that gets thrown around a lot and not really adequately understood, but we all fast when we sleep, right? None of us are eating a donut while we're snoring. But there's different windows that you have more and less to gain by a fast. So there are different windows of fasting that will help with different types of things. And one thing that really helps kind of empty out the tanks so that your glucose is not so high when you're fasting is to do the 3 hours before bed, no calories. What that does is it starts your body into fasting mode before you get your growth hormone spike at about 4 o'clock in the morning. And so when your tank is already empty, when that growth hormone spikes, you tend to get the best insulin sensitivity and the lowest glucose numbers throughout the next day.
Hmm.
And this is something that works much better in men than women for some reason. Women don't tend to respond as well to fasting when it comes to emptying the tanks. We tend to have more of a cortisol response that offsets that balance. And
Hmm.
I have a feeling that might have something to do with our estrogen levels being higher than yours. That's kind of the theory, but we're not 100% sure. But for men, that's a very good method is just decreasing the calories or eliminating calories 3 hours before bed. So a low insulin, you really have to put the whole picture together. So a perfect number is around 6. Um, Anything above 10 is the start of insulin resistance. When it's low, you either have somebody that is incredibly efficient with their insulin. So you only need a tiny little bit in order for your cells to get turned on and suck it up. And I'm sure with you, it's because you're moving your muscles. So
Yeah.
that mechanism where I told you that the muscle cells send straws to the perimeter to suck up glucose, you are doing that all the time. So your
Yeah.
pancreas doesn't need to shoot out a lot of insulin.
Got it.
When I see this on a diabetic or a pre-diabetic, I go, can they even make insulin?
Mm. Interesting question for you. If, at a certain point in my life, if my activity drops, will my pancreas be able to adapt pretty easily to increase the amount of insulin that I need? Or is it something that like I should be concerned about in the future?
No, that's a great question. So you have cells inside of your pancreas called islet cells that are responsible for making insulin. And the more sensitive your cells are and the more efficiently your body is using it, it's taking the heat off of them. So yours are healthy and they're primed and they're ready for when you need them. There is another test called C-reactive protein. C-reactive protein, sorry, C-peptide,
Mhm.
peptide C, that can tell you how efficient your pancreatic cells are. So you can actually test that. But no, you've saved your islet cells from a lifetime of stress. They will be there for you when you need
Okay.
them,
Awesome.
provided you don't suffer some sort of trauma to your pancreas or pancreatic cancer or anything like that that would destroy your pancreatic cells, individually
Got it.
outside of this mechanism. Yeah. Iron. So one thing, when I talked about the intracellular micronutrient testing, the difference between just a regular vitamin B12 and an intracellular B12 is a huge difference. When we measure and we take your plasma and we check for these things, it's basically just what's circulating in your blood for the last 24 to 48 hours. So if you took a vitamin B supplement by mouth that morning, your level will be higher. And if you skipped your supplement that day, your level would be lower. If you really want to dig deep into your intracellular nutrients, it's a very special test where I send off the blood. They actually separate out a bunch of your blood cells, put them all in dishes, and then subject them to all these nutrients and watch the cell growth to determine how well your body is actually utilizing these nutrients from an intracellular standpoint. It will give you much better long-term data. So this is more of a snapshot of, you got your blood drawn on the first. This is more of a snapshot of what you ate between the 31st and the first. And
Mm.
so if you had a steak, that night before, your iron's going to be on the higher side. And if you ate a salad for dinner the night before, then maybe this number would be 90.
Got it.
So what I look at really is more of the percent saturation. And you're just under the upper limit where I would start to say, are you keeping too much of your iron? Maybe you do have one of those genetic variants that causes you to hold on to your iron a little bit better. But I would definitely just match this with your next blood test of your iron and see kind of and average the two numbers together. And I wouldn't want you to supplement this number and go any higher. But if next time I drew it, it was 200, then I would say, we need to consider that you might have a genetic variant here that is causing you to keep too much iron, and we might want to limit your iron that you're taking in, and that would be limiting some red meat, or maybe looking for things that are causing you to hold on to it for too long. One common thing is taking vitamin C at the same time as your meals. It will cause you to hold more iron in.
Mm.
And so in patients that are supplementing vitamin C and have a very mild presentation of this, I'll just have them take their vitamin C separate from their food, or eliminate the vitamin C or lower the dose. But yeah, this is a number that doesn't concern me where it is, but if it were to go a lot higher than that, I would want to vet this a little bit further. The vitamin B12, I would like to see you actually a little bit higher on a day-to-day basis, which means you would either want to do an intracellular test to see really what your real level is, or just increase, if you're taking any supplement of vitamin B12, I would take a little bit of a higher dose just to kind
Yeah.
of get you closer to the upper end of the range. Your triglycerides are beautiful, and that tells me you are emptying out your tanks overnight pretty well. You'll start to see this number go up on patients that eat ice cream before bed, or go out and drink alcohol and then hit Taco Bell on the way home. Anything that's like overfeeding them when the body has nothing to do with it and your muscles aren't going to move, it immediately is going to go to triglycerides. And triglycerides, it's funny because they sit with the cholesterol. They're actually more of a metabolic marker than they are a cholesterol marker.
Mm.
But they stick them in here. Your total cholesterol is really less important than your LDL cholesterol, because your total cholesterol includes HDLs. HDLs are actually the molecules or the carrier proteins that are going to get rid of the cholesterol in your body, carry it away from the organs, away from the artery wall, and bring it back to the liver and then to the gut to be excreted. And so we kind of back this number out of the total cholesterol to determine your risk. We want to know your non-HDL cholesterol, and that's your LDLs, your VLDLs. Some people look at an apolipoprotein B to get that number as well. The only reason I don't like an apolipoprotein B to replace a cholesterol panel is because you don't then get the triglycerides.
Mm.
And the triglycerides are important. So that's why I order a lipid panel. The LDLs are pretty much very consistent with an apolipoprotein B, will be a tiny little bit higher usually than the LDLs. And if you use this metric to monitor therapy and you watch this number going down, once this number gets to about 50 or 60, that's when you've gained really good control, especially in a patient that's a higher risk patient. So, for you don't have high risk, but I would get ahead of this number. I
Yeah.
would like to see this number closer to 70, with your general health and lack of cardiac risk. These are this is the ratio. They used to really rely a lot on the HDLs to determine how healthy you are, because we know that this number helps carry cholesterol away from the arteries. So that's why this ratio is how they calculate cardiac risk. This is being steered away from a lot because of the fact that just because somebody has a high or low HDL doesn't really mean that they're effectively transporting the cholesterol out of the body. It could be low because they don't build them, or
Mm.
it could be high because they have too much cholesterol to carry away, so it upregulated. And so this thought process that we can really rely on this ratio to determine risk is now very much called into question, and honestly really shouldn't even be on a lab report anymore, in my opinion. Homocysteine, that's that inflammatory marker, methylation marker that we talked about. Vitamin D. Report card perfect. Your thyroid panel. So this is the thyroid panel we talked about. If you just go for your regular annual screening, chances are your doctor's ordering just the TSH.
Mm-hmm.
And the way they write it on the lab slip is they'll tell the lab, I want this patient to have a TSH test, and then reflex T4 if positive. So what that tells the lab is as long as the TSH is within this range, don't do anything else. If the TSH is out of this range, then you can go ahead and test the patient with this. The problem with that is about 20 years ago, the Endocrine Society decided that the highest the TSH should be is 2.5. Look at this lab slip. It flags it at 4.78, even though we shouldn't accept that number. It should not be that high. It should only be 2.5. Mm-hmm. And so if somebody has a 2.6, they're not going to get that test.
Yeah.
If somebody has, it's going to take them becoming 4.8 in order to get that test. And so right away, you know that this limited evaluation is missing so many people that have inadequate thyroid, and we'll never know because we're not going to look for it. The other thing that is very uncommon to screen for are these antibodies. And those are the antibodies that sometimes people with Hashimoto's or celiac disease will develop. And that can affect the thyroid gland because the more it gets attacked by the immune system, the more inflamed it gets. And inflamed cells don't do a good job at making hormone, binding hormone, or having good blood flow to them, which will affect future hormone. So really, identifying this when the numbers are high and starting a gluten-free diet to see if that helps. And if that doesn't help, then exploring a little bit further to find out what the issue is. Is it the gut? Is it a dairy sensitivity? Is it something else causing that attack before it starts to really affect the thyroid gland to where it goes beyond this number and somebody finally identifies it?
Got it.
It's a huge miss in mainstream medicine right here. Cookbook medicine just ordering the same labs on everybody and then only scanning the lab at the doctor's office just to see anything that pops out, but not really caring what end of the range you're in. You got to know what end of the range you're in and what you're supposed to be, and things like this, knowing that, does every internal medicine doctor know that? I'm not sure. They probably wouldn't order the test that way if they did know that, right? Because they know the lab cutoff is so much higher than it should be.
Yeah.
Endocrine evaluation, these are the sex hormones. So this LH1 here is the one that I look for in men to see if they're interested in testosterone replacement. This will help tell me, is it coming from the brain not sending the signal, or is the low testosterone because the testes don't want to make testosterone anymore? And so your numbers are beautiful. Your total testosterone, 621, your free testosterone, 13.6. That free level is beautiful. I supplement men to get them to this level. I have some men that don't feel good until I get them up to 800 with a free of like 22. You really look at testosterone based on symptoms in response. If you're putting on adequate muscle, if you are having adequate energy at the levels you're at, then you don't need to boost it.
That makes sense.
Mm-hmm. And I can give somebody testosterone until their level's up to 1100, but if their body's inflamed, if they're not binding well, if they have a really high sex hormone binding globulin, then it won't be as useful to them. And so I can fill the tank as much as I want, but the key's got to connect in the lock. Your sex binding globulin is good, 31 here. DHT, that's the metabolite of testosterone that your brain uses for libido and that androgenic energy, male energy. And yours is beautiful. 30 is the number that I aim for. Again, right on the number there.
So generally, like to say, if that was like closer to the 11, someone probably has like a zero libido, low libido, versus 95, someone's like revving all the time.
Exactly. Yeah. So some guys ask, well, if this is good for my libido, why don't I want to be at 95? And this is why it's so important to know what end of the spectrum you need to be at, what area, what quartile within this range is the safest. because if you're below 11, then you're probably not going to have a great libido or great energy. If you're above 95, this metabolite unfortunately stimulates the prostate a lot, and it
Mm.
also is in hair follicles. So the reason why I don't want to drive men to the upper quartile on this one is because it might cause them to lose hair. Which is maybe if you've ever heard people say, oh, you're bald because of your testosterone, it means you have high testosterone.
Well, it's
Um,
because it's something they are producing more DHT. So a lot of the medications that people take are DHT block. I don't know if blocker is the right word, but blockers, and that's why a lot of really negative side effects that people experience with these are a low libido, low sex drive, inability to get erections. And I recently heard. I think you when we spoke first like a year and a half ago. I think you originally had told me about Dr. Peter Attia.
oh, yeah.
And I just recently heard him on a podcast talking about the negative side effects of DHT blockers and how they even after stopping to continue taking them, you will still continue to have these negative side effects.
100%. It's not very common, but men that do experience low libido from using those blockers to prevent excessive metabolization of DHT can develop what they call post-finasteride syndrome, and it can be permanent. About 2% of men that experience it, it can last forever, even if you get the levels back to normal. And we don't
Mm.
know why that is. But that's why it's important to see on this number, you want to be in the middle of the range. You don't want to be at the end, either one of the ends of that range. You want to be dead set in the middle of it. And the men that are taking testosterone in a way that causes large spikes and then deep troughs are the men that are most likely to suffer from bad metabolites,
Mm.
because you give your body a huge bolus all at once to deal with, and your body can only use so much of it. So the rest of it gets shifted into a metabolite, either estrogen or DHT. And depending on what path they go down, if they favor one more than the other, then you can see excessive elevations of the DHT, or sometimes on men, specifically men that are subject to gynecomastia or man boobs, you'll see those men tend to have a genetic variant perhaps that makes them push their metabolites more to the estradiol than to the DHT. And then
Mm.
you see those symptoms. So yours was
Interesting.
flat as high. This doesn't bother me. First of all, it's just above the upper limit of normal, which I don't normally shake that one off, but in this case you can. You can be between the 80th and the 100th percentile on your estradiol because you have good cardio benefits from this. This is benefiting your cardiovascular system, decreasing the amount of plaque you're laying down, and also increasing your bone density.
Interesting. But that is what leads to gyno.
If it's too high. Yeah.
Interesting.
Yep. And then the other thing too is to break this estradiol down. When I see, so the next time we do your labs, what I would do is also order an estrone. I wouldn't expect your estrone to be high, but estrone is a type of estrogen. You see, this says E2. Estrone is E1.
Mm.
Estradiol is the most common estrogen, but estrone is a bad estrogen. It's an estrogen that comes when, remember, I told you that your testosterone will eventually break down and become estrogen? When it does it in your fat cells in your body have a enzyme that switches the testosterone instead of to estradiol to estrone. And that is the bad estrogen. And
Mm.
that can contribute. Sometimes, if you just check estradiol, the lab will give you a combination of all of them. And so some of this could be overlap from the estrone. So I would order a separate estrone and estradiol on you next time to see if maybe this separates out at all,
Got it.
because sometimes you're getting some estrone in this calculation. You don't have a lot of body fat though, so I wouldn't expect that on you. I would expect that if we did that to you, we would still see the 41 here, and then your estrone would be like 3 or 2,
Okay.
just because I don't think you're converting your testosterone to estrone in fat cells because you
Mm.
just don't have enough fat. Your progesterone is a little bit low. Progesterone is kind of the grandmother of your hormones. In the whole hormone cascade, progesterone is even above testosterone. And so sometimes supplementing with pregnenolone. Have you ever heard of pregnenolone?
No.
Sometimes substituting with pregnenolone can help with that. It's a pre-hormone. It's available over the counter. You can get it from a vitamin store. I can give you a link from my full script to order it. I wouldn't do DHEA because even though your DHEA is low normal, it's still good for your age. And if I supplement your DHEA, it's going to increase your estrogen a little bit.
Mm.
You're already at the upper limit on that. But I think that you might actually benefit from a pregnenolone supplement. That might be something. We started about 30 milligrams a day for you. Yeah, your
Well,
prolactin
awesome.
level is really good. Yeah, yeah, your labs look amazing. I
Well,
mean, a few things I would recheck here and there, but I mean, you're the specimen of health.
well, thank you. This is so enlightening, Jen. And I learned so much about my health. I learned so much about just tests and hormones and what we should be looking for. I would love for people to be able to know where to find you, whether to work with you, hire you. So I'm wondering, like, where can people find you? So, like, whether it's a website, social media.
Absolutely, yeah. Noble Family Medical is the name of the practice, noblefamilymedical.com. Same on social media on Instagram, Noble Family Medical. And yeah, give me a call or shoot me a text on my website. There is a link to set up a discovery call. Typically I just like people to call me and talk about what they're dealing with, and I'll let them know how I can help them and what my method of attack would be. And yeah.
I encourage all the listeners to not sleep on this. Definitely hire Jen, get this done because it's very clear that your doctors are not doing everything that they should be doing. Not to say that they're probably not doing, they're doing the bare minimum, which is for, I think, a lot of people that, they should really be investigating deeper into the numbers. And I think, as Jen and I can attest, both working in the health field, any money that you spend on your health is an investment. Because the only thing we don't get back is time.
100% very well said. Your time is so important. Your health is wealth. And, I think we're doing a great job in the traditional medical system at treating disease, but I'm not here really to treat disease. I'm here to make sure that people don't get disease. I'll treat it if I see it, but I'd rather prevent it than treat it.
Well, thank you, Jen. I can't wait for
Yeah.
people to be able to listen to this.